this to our lunchtime promise. I am so grateful that Dr. Homme and Dr. Benning have agreed to be here today. Many of you first encountered this article when Pediatric Chaplains Network did a journal club on it, which I heard went really well. And I just thought, I think it would be fun for us to actually hear from the authors and to really, think about and talk about how this method could be applicable. And I think that's sort of, this shift with the research network is that we sort of take the research and then like to say, how might we replicate this? How might we use this really to continue doing research to further the profession? And I said, before some folks hopped on, transforming chaplaincy, which I think most of you on here know, but just to give kind of the overview, transforming chaplaincy is what I call the umbrella organization that then our research networks kind of break out into specialties within transforming chaplaincy, and transforming chaplaincy, but not separate from the research network, but with a little bit more sort of a larger institutional backing, is looking at doing a pretty significant study of pediatric staffing, because that's a huge issue that comes up. And so as we've been starting to plan that study and talk about that study, I read this paper, which is about chaplaincy service utilization. And I just thought that they fit together so well. And so I wanted to continue this conversation and really bring some more chaplains here. So you all, Dr. Homme and Dr. Benning, can also be in conversation with our pediatric chaplains on the ground. I know you certainly are with the chaplains in your site, but we're a close-knit and international bunch, actually. I invited some folks from Hungary and Spain and UK, so we'll see if it's not a weird hour for them. But Dr. Benning, if you'd like to start the slides, and then we can go from there.
All righty. All right, is that sharing correctly?
That is. Do you want to head to the next slide? So the objectives for this time together, and I always think objectives are sort of moving targets, but it is to sort of understand the evidence base for the importance of spiritual care for children with chronic illnesses. Which I think was a really, for me, reading this paper was a pretty key piece, because I know as a chaplain who primarily worked in sort of complex chronic care, I sometimes felt like the literature and resources were lacking around chaplaincy in the population. Although many of you probably know Daniel Grosamy, who's a significant researcher in pediatric chaplaincy as well, who has done a lot, particularly with children with cystic fibrosis. So there is some literature there and some work done there. But that chronic illness piece, I think, is really key. And explore the methods, and particularly the method these authors use to research chaplaincy service utilization in pediatric and other populations. And then to identify gaps in chaplaincy utilization and the opportunities for service improvement. You can go to the next slide. Dr. Benning is a pediatrics resident at the Mayo Clinic, where he attended medical school at Mayo Clinic Alex School of Medicine. In collaboration with Mayo Clinic's pediatric chaplains, he explored the ways that hospitalized children and their families utilize spiritual care services, and is interested in ways that chaplains and spiritual care can be better integrated into medical care. Which that is just like speaking our language. We love that phrase, how can chaplains be integrated? And he plans to pursue fellowship training and is exploring multiple pediatric subspecialties. You can go to the next slide. Welcome, Dr. Benning. Dr. Jay Homme is a staff physician at Mayo Clinic in Rochester in the Department of Pediatric and Adolescent Medicine, which is in the Division of Community Pediatrics and Pediatric Hospital Medicine. His professional interests include undergraduate and graduate medical education, so training this next generation, including Dr. Benning, evidence-based approaches to diagnosis and management of common conditions, support and care of children and families dealing with medical complexity, and integrating the care of children across the continuum, including ambulatory and inpatient. So welcome so much, Dr. Homme. Thank you for being here.
Thanks for having us.
Go to the next slide. And here we are. So welcome, Dr. Benning.
Alrighty, thank you. And thank you all so much for having us here this morning or afternoon, depending on where you're zooming in from. And I think I speak for both Dr. Homme and myself when I say we are very excited just to hear that someone has read our paper and is interested in talking about it. So we're very happy to be here with you today. And Dr. Homme, would you mind monitoring the chat and just letting me know if anything pops up, and feel free to jump in with chat questions, and we'll have time for questions and discussion at the end.
Absolutely.
Alrighty. So I'll kick us off. So just a little context and framing for today. So we all know that spiritual care is important for children and for adults. And we also know that there are kind of some traditional contexts in which spiritual care is often seen as more relevant. People often think of chaplains being involved in really acute care, kind of in palliative and end-of-life care. And often, especially in the pediatric population, we think of chaplains being involved in oncology care, but not necessarily as much in other areas of care. However, we know that among hospitalized children who are seen by chaplains, about 50% are chronically ill. This is a very large population of our hospitalized children. We also know that just in the community population, about 20% of children have chronic illnesses that have functional impacts on their lives. So this is an important population to be studying. And Dr. Homme is just going to share some more of his context with us.
Yeah, as a practicing pediatrician, both in the clinic and the hospital for over 20 years now, it really struck me in my hospital practice the frequency with which we would see children back in the hospital, and the duration that some of them would spend there, both through chronic illness and other challenges, and the importance of all members of the care team in helping to meet both their medical and their spiritual needs. And when Tyler and one of his classmates approached me and some others about this study, it really was a great opportunity to discuss some of these points that he's already raised, which is the chronicity of care and the complexity of care for children in the hospital setting is increasing over time, but also changing in some ways. Some patient populations we're seeing in the hospital less, like cystic fibrosis patients, as a better outpatient management. We're having them hospitalized less, but others that are more technologically dependent, we're seeing in the hospital for greater periods and more extended periods of time, and how we can integrate chaplaincy into meeting their needs and the needs of their families and caregivers was really an important driver for why we decided to proceed with this study.
Yeah, absolutely. And just taking a look at the current literature on pediatric spiritual care, numbers aren't everything, but just to give you a sense, if you go to PubMed and are searching for pediatric spiritual care plus specific conditions, if you're searching for studies on cancer, on palliative care, or on end-of-life care, you're getting about 200 different research studies coming up for each of those conditions. Whereas if you're looking at more common chronic conditions for kids, things like pediatric spiritual care and asthma or diabetes and epilepsy, you're only getting single-digit numbers of studies. So this is an area that is understudied in the academic literature. So in general, though, we can go through a few findings about the importance of spiritual care in chronic disease. We do know that a sense of spirituality alters people's understanding and their management of their chronic diseases. This makes sense, especially if people are coming from religious traditions that have kind of a rich history or a rich tradition of understanding suffering. This can certainly impact how children and how parents are conceptualizing the disease, and are kind of conceptualizing some of the challenges and some of the suffering that comes along with those diseases. We also know that it influences coping skills. Often spirituality can be a positive influence on coping. It can provide people with resources in a community of people who understand them and have similar values to them, and more individual methods of coping, such as prayer, lamentation, can be very effective. Also, there can sometimes be negative effects on coping. People may feel tension between what they feel that their religious faith is calling them to do and what doctors are recommending they do. And in some cases, they might also see their child's disease progression or simply not getting better as a sign of a lack of faith, or as something that makes them question their relationship and even question their belief in God. So it can be a variety of positive and negative influences on coping. We also know from prior research that adolescents at least desire integration of spiritual care into their chronic care, which I think is an important point. We want to make sure that spiritual care is not something that's being imposed from outside. A lot of these kids, lots of their life is dictated by what their doctors recommend, by what their medical team recommends, and by what their disease dictates. So it's important to note that at least in this study, adolescents were expressing that this was something that they wanted and something that they felt would be helpful for them. We also have, like I mentioned, a handful of studies focusing on specific pediatric chronic diseases. We know that in the context of diabetes, spiritual intelligence is associated with better diabetes self-management and fewer complications. We also know in the context of cystic fibrosis, people with negative religious coping skills actually have more rapid pulmonary decline as objectively measured on pulmonary function testing. We also know that for irritable bowel disease, spiritual care is associated with better emotional well-being. And interestingly, this association is much stronger for kids who are chronically ill with IBD than with kids in the general population. I'm suggesting that spiritual care is especially important in this context. All right, so that's a little bit of a groundwork for some of the things we're going to talk about today. So specifically for today, researching spiritual care services. So we were asked to talk a little bit about the methods that go into researching spiritual care utilization. So we'll go a little bit more into detail on some of these methodological considerations of our paper than we might otherwise go into. And so kind of the outline will be running through some of the big questions that you have to think about when you're designing a care utilization study. We'll talk about those questions and then we'll kind of run through how we answered them in our own study. So to begin, one of the first tasks when conducting a research study on utilization, you need to define the population that you'll be studying. So one of the first things to consider is whether you're going to be researching a broad or a narrow population. In terms of a broad population, you could be as broad as everyone who comes into the hospital under 18 admitted for any reason, or you can get very narrow and specific. You might specifically be looking at kids with new onset type 1 diabetes who are admitted to the hospital for management. The ideal population for your study kind of depends on what the goal of the study is and what you're hoping to accomplish. If you're hoping to test general theories of spiritual development or kind of develop a general understanding of spiritual care utilization, often a broad population is more helpful, so findings are more easily generalizable. But if you're looking to make more granular research, or especially if you feel like there is a certain population that maybe in your institution or in the country as a whole is not receiving ideal spiritual care, it can be better to have a more narrow study, which you can then use as evidence for not providing adequate spiritual care to a certain group or to a certain class of patients. And then populations can often be stratified based on age because the spiritual care needs are so different for younger versus older children, also based on specific disease and the level of care, because often chaplains are more involved in the highest acute care floors like the ICUs rather than more of the general care floors. Another thing to consider for your population is what the time frame of your study will be, whether you're going to be collecting data over a relatively short period or a long extended time frame. Often long-term is better since you'll be able to get more data and you'll have more statistical power in your data, but there can be advantages to shorter term studies too. Sometimes there are big events, COVID for example, that really change the way that spiritual care and medical care is delivered. So in some cases, it's more advantageous to restrict your study to a short time when you know that there weren't any of those large intervening events that would really change how spiritual care was delivered. And sometimes there are just practical considerations that make you use a short-term time frame. Like for example, maybe there was a new electronic medical record that was implemented and you only have data going back to a certain point. That's often the case. Thinking a little bit more about your population, it's important to determine what your exclusion criteria will be. Often studies will exclude patients based on things like length of stay or acuity of condition or language barriers. It's important to think critically about these exclusion criteria, how they affect your population, whether it makes it non-representative, and how that influences how you interpret your study. And this is also an important time to think about equity considerations. For example, if all of the chaplains in your institution mainly speak English and you're excluding non-English speakers from your study, that clearly has equity implications. And this is an important stage to think about those considerations. And then you also have to think about what is your unit of analysis going to be. which is basically the fundamental unit of your study. Are you going to be calculating your outcome metric in terms of patients, in terms of admissions, in terms of length of stay, like how many days are they seeing a chaplain during their visit? So it's important to establish that right up front. So running through our study, kind of how we addressed these questions in our study. So what we did was we selected the most common chronic health conditions based on the Healthcare Cost and Utilization Project, which showed us the 6 most common chronic reasons that children were admitted to the hospital. So we found that asthma, epilepsy, diabetes, sickle cell, IBD, and cystic fibrosis were the most common conditions. For our study, we set our time frame from May 2018 to December 2019. The reasons for these choices were May 2018 was when we implemented a new electronic medical record, like I had mentioned, so it made data collection easier. And then we decided to stop collecting data before effects of COVID were going to be seen, just to have a more homogeneous sample to analyze. We also excluded patients with sickle cell due to a low local prevalence at our area in Rochester. And then we also excluded patients who were admitted for acute concerns unrelated to their chronic disease. For example, if a child with diabetes was admitted for a tonsillectomy, we didn't include that, so we focused strictly on admissions that were for management of their chronic disease. All right, so next consideration to take into account when designing a study like this, you have to decide what type of measurement you're going to use for your outcome variable. So you can broadly think about 3 different types of measurements: structural, process, and outcome measurements. Structural measurements are things that relate to resources and capabilities and institutional arrangements. For example, examples of structural measurements might be how many chaplains are on staff, what percentage of chaplains have specific degrees, what is the chaplain to patient ratio, things of that nature. These kinds of questions and metrics can be useful for benchmarking and seeing how an institution compares to national standards. And these studies are often most useful if they're multi-center to provide a broad base for comparison. Process measures are measuring things that occur in the hospital and things that we think are related to the outcomes we care about. For example, things like how many patients get chaplain consults, what % of patients are completing a spiritual history form on admission, how are chaplain consults being initiated, things like that. And then we also think about outcome measures, which are ultimately the things we care about. Things like level of anxiety for patients, amount of loneliness, how long they're staying in the hospital, their level of satisfaction, morbidity, mortality, things like that. These are often the most difficult to measure because they're often not recorded unless they're part of a prospective study that's specifically designed to record them. So often these other measures you can get from things like retrospective chart review, but outcome measures often but not always have to be gathered as part of a prospectively designed study, which is methodologically more challenging. And one of the topics that I'd love to talk about in our discussion is what outcome measurements are actually most relevant to chaplaincy, because I would argue that some of the most relevant metrics are things that we can't necessarily measure even on things like surveys of depression or surveys of loneliness. Those don't necessarily capture what it is we're hoping to accomplish through a spiritual care consult and through chaplain involvement. So that'll be a topic for a little bit more discussion later. So for our study, we had a fairly basic measurement for chaplain utilization. Within the chart in our institution, we could see documentation of 4 different levels of chaplain service for each patient. There was no attempt to contact a patient, there was an unsuccessful attempt. In some cases, a chaplain would contact a patient, but they would say, no, we don't have any spiritual care needs, or the level of contact that we cared about was a chaplain visiting a patient and then completing a spiritual care consult. So for our purposes, we are measuring the number of level 4 contacts in our institution. So back again to methodological considerations. An important thing to think about when designing your study is what subgroups you're interested in and what potential confounders there are. So if you're doing your research on a very heterogeneous group, it's important to think whether there are subgroups that might behave differently than others. So for example, in our study, we had lots of patients with epilepsy admitted, and patients in our institution are often admitted for short stays to the epilepsy monitoring unit. which is kind of a different stay from an acute disease exacerbation that might bring in a patient with diabetes or a patient with cystic fibrosis. So one of the things we considered was whether that subgroup might behave differently from other groups. Also important to think about confounding factors that might influence your outcome variable. A practice that I like for considering confounding factors is trying to take a multidisciplinary approach and thinking about what your outcome of interest is. So in our sake, chaplain utilization, and asking lots of different people, what are all the factors you can think of that might influence this outcome? And you can imagine if you ask this to a multidisciplinary team, physicians might say something like, oh, well, patients who are intubated or sedated might not be awake enough to ask for a chaplain, so that could influence your outcome. Nurses might mention something like language barriers make it harder for staff to assess spiritual distress in some patients. So that could decrease utilization for non-English speakers. And then if you ask this question to chaplains, you would all have insight into some of the specific workflows. For example, are there specific groups of patients that get automatic consults versus someone needing a nurse or physician to put in that consult? And there are a variety of options to address your subgroups and your confounders. You can narrow the population to focus on a specific subgroup. You can exclude certain subgroups. If you're running a statistical regression, you can control for some of these confounding factors. And there's always the option of just acknowledging in your research that a limitation is that you have a heterogeneous group that is not the same across all relevant metrics. So for us, a few of the relevant confounders and subgroups we considered, one was length of stay. I think it's pretty intuitive that children who have longer lengths of stay are more likely to use chaplain services. So we specifically looked at rates of utilization based on length of stay. Religiosity is another very important variable. So we statistically compared rates of utilization between Christian and non-Christian patients, as well as affiliated and non-religiously affiliated patients. And like I mentioned, we saw whether patients with epilepsy had different utilization rates since they were often admitted for different reasons. And then one of the last things to think about when designing your study is making an analysis plan. So this is a really important part of the study and often one of the challenging parts, but it's important to prospectively plan your analyses so you make sure that you're running analyses that you have decided in the beginning to run and not just kind of going around to interesting findings and trying to run an analysis on every single interesting finding. The reason for this is something called the problem of multiple comparisons. And essentially, if you take a group of data and run indiscriminate tests on it, if you run 100 tests, a certain number of them are going to come back as statistically significant, even if they're just randomly due to chance. So in order to eliminate that possibility or at least reduce it, it's important to set out at the beginning of the study and decide what analyses you're going to run in advance. It's also important to involve a statistical expert early in the process. If you have access to a statistician or a research methodologist, they can often be very helpful in letting you know what types of analysis will and won't be possible given what data you have and also what types of data to collect. And there are a few things worse when you're doing research to spend hours going through charts and collecting data only to realize that you actually, for statistical reasons, don't have the data that you need to run proper comparisons. And this is often the case if you're trying to look at time series data. So that's an important thing to keep in mind if you're looking at data over time, as we often do for chaplain studies. And a final important consideration is statistical power. This is a problem throughout pediatrics, and I imagine in pediatric chaplaincy as well, but often we're just dealing with small sample sizes. And so when you're comparing small groups to each other, you might often see that there's no statistical difference between the groups. And that can be not because there's no underlying difference, but actually because your groups are just too small to show that difference. So it's important to make sure that you're running comparisons on groups that are large enough that your result is actually a meaningful result. And it's certainly okay to revise analysis plans as new data comes to light, but you want to make sure that you're not just running after all the different interesting findings in your data, but actually doing things that are theory-based and that are related to your original research question. So for us, when we made our analysis plan, we decided to calculate utilization rates as the number of admissions divided by total of admissions and calculate confidence intervals around this result. We also compared subgroups based on religiosity and on the length of stay. And then we used a technique called logistic regression to predict chaplain utilization. So I also want to briefly go over some of the results of this study before we get into some of the question, answer, and discussion time. So I've picked out some of what I think are the interesting and useful results from this study. So just to give you an idea of who was included in our study. So there were 629 unique patients in our study that had 915 admissions over our study period. The plurality of our patients were Christian, religiously affiliated based on self-identified information provided by them or by parents. We also had a large contingent who chose not to disclose a religious affiliation, and then a decent number of religiously unaffiliated patients as well. And we had only a small number of people who were religiously affiliated with non-Christian traditions. And then looking at who made up our study population, the largest single subgroup in our study was patients with epilepsy who were admitted for epilepsy reasons. And we had smaller amounts of patients admitted for asthma, diabetes, irritable bowel disease, and cystic fibrosis. And then this is just a bar graph showing that data that I had previously shown a couple slides ago. So you can see that the single largest group is religiously affiliated Christian patients with lower numbers of other religious groups identified in our study. So this slide right here is really kind of the central top line finding of our study. So we saw that among those 916 admissions that we were looking at, only 5% of the admissions included a full chaplain visit in which the chaplain was able to meet with the patient and then have a successful spiritual care interaction. And that number was much lower than I was expecting. It's actually significantly lower if we compare to some other Mayo Clinic data published for the adult population. That number is significantly lower among children compared to adults. So looking at a few of our subgroups that we mentioned that we were interested. So I was actually interested to find that there was no significant difference in chaplain utilization among Christian patients versus non-Christian patients. You can see that 7.3% rate versus the 7% rate. And interestingly, there was also no significant difference between religiously affiliated and non-religiously affiliated patients, which is not what I was expecting to find when we set out to do this study. I will talk a little bit more about reasons that might be, but I think an important thing to keep in mind from this slide is that patients who you might not classically think of as being interested in or wanting a chaplain visit appear from this data to still be interested in speaking with chaplains at essentially the same rate as populations that you might think are more classically interested in chaplain care. We also took a look at utilization rates by length of stay. And as you would expect, we found that as children stayed longer, they were more likely to utilize chaplain services during their stay. One of the challenges in pediatric chaplain care is thankfully many kids have very short admissions. They're admitted with a respiratory condition, for example, and then they're able to be weaned off oxygen in a couple days and go home, which is good for the children and good for the families. But those hospitalizations can still be very challenging and very taxing times. And just from a workflow perspective, it can be difficult if someone is only admitted for 48 hours. It can be difficult for the care team to identify spiritual distress, get a chaplain involved, and then have a chaplain come visit all before the patient gets discharged. We also found as we were looking at length of stay for the patients who had very long stays greater than 10 days, often chaplains were not getting involved until relatively late in the stay. So someone might have a 2-week hospital stay, but a chaplain wasn't able to see the patient until day 10, 11, or 12 of stay. And you can imagine that an earlier visit with a chaplain might have been beneficial for families. All right, so a few broad discussion points before we turn it over to the group for more group discussion. So there was low overall use of spiritual care resources among children admitted with chronic conditions. There are quite a few possible explanations for this. One is simply chaplain availability and the FTE that's available to provide these spiritual resources to family. We didn't show this data, but actually during our study, we hired an additional part-time pediatric chaplain And we saw that after this second chaplain was hired, utilization rates overall increased, which suggests to us that there is a staffing capacity issue, and that if we had more pediatric chaplains available, more families would like to receive visits from chaplains. I talked about how the short length of stay can also make it difficult for chaplains to see patients. Some other possible explanations would be a lack of a standardized or lack of an efficient referral process. We don't have a lot of standardized protocols in our hospital, at least, that involve spiritual care consults. So it's often up to a nurse or a provider to recognize that a family could benefit from spiritual care. There might be a lack of patient or family knowledge about spiritual care resources that are available. It's not something that we necessarily advertise well. So we might need to make people aware of these resources. There's always the possibility that patients or families simply might not desire spiritual care, which is always an option that we should keep in mind. And then I think another one of our interesting findings was the lack of significant difference between Christian and non-Christian groups, as well as between religiously and non-religiously affiliated patients. One interpretation of that is that even patients who don't belong to a formal tradition can still benefit from a lot of the approaches of chaplains and a lot of the skills that chaplains have. Even if chaplains aren't engaging in specifically spiritual or specifically religious language, a lot of their skills and abilities from their training translates very nicely into non-specifically religious and non-spiritual settings, and patients can still benefit from that. And then, so a few implications from patient care, and this is our last slide before getting to some discussion. But recommendations based on this study would be to involve chaplains early, especially if a long stay is anticipated. I'm thinking again of those patients who are staying 2 or 3 weeks, but no one thinks to alert the chaplain until day 10 of stay, at which point it's probably too late to have optimal impact, though they can certainly still benefit the patients and the families. I think doing assessments of the spiritual needs of both children and caregivers is important. It may not be a formal assessment. I know when we run through our admissions, there are many, many boxes to click and forms to go through, and adding a formal assessment might not necessarily be beneficial, but I will often find myself doing informal assessments. You can sometimes walk into a room and you'll notice things in a room, like maybe parent is wearing a crucifix, maybe you see the Quran on the table, maybe you see someone's phone ringtone is a church hymn or something like that. Those can all be clues that this is a family that might benefit from some spiritual engagement. You can also pay attention to the language they're using. If they're talking about losing faith, feeling abandoned, things like that, that could also be an indication that they have some spiritual needs. And I think it's also helpful to just make sure that families are aware that chaplains are available if they decide that they would benefit from speaking with them. All right. So we'll have a couple things for the rest of our hour. So I've put together a few group discussion questions that I would love to hear people's opinions and thoughts on. And then after we discuss these topics, we'll have a little bit of Q&A time as well. And if discussion blends into the Q&A, that is just fine. But I will put up our discussion questions here. And so things that I would be interested in discussing and things that I think Dr. Homme and I could benefit from hearing about are a few topics. So one is, how do spiritual care needs differ between acute illnesses and chronic illnesses? I think those needs definitely differ, but pulling out those specific differences is important. I'm also interested in talking about what outcomes matter the most when providing spiritual care to children and families with chronic illnesses. Some of those will be measurable, some of those will be unmeasurable, and I think that's something we have to accept in this field. And then I'm also interested in hearing about any specific programs or practices from all the institutions we have represented, whether there are any specific practices for children and families with chronic illnesses that seem to work particularly well, and maybe we can all learn about those and benefit from those. So with that, we'll just open the floor and feel free to jump in on any or all of these discussion questions.
There was a question in the chat about, do we have cultural and racial background breakdown information? And I included that. We do have that in the paper, and it's in table 1. I'd be happy to show that if desired. You got it there, great.
Yep, yeah, so that is our race and ethnicity breakdown. So it was kind of reflective of the Rochester population. So predominantly white, 78% white. then you can see the other races and ethnicities listed there.
We have a fairly large referral practice, patients coming from a great distance, but looking specifically at some of these chronic illnesses, they tend to be individuals that live closer and more frequent hospitalizations, with the exception of some of the epilepsy population that are specifically coming for epilepsy monitoring unit, and those generally somewhere between 1 to 3 day stays.
I believe that everyone here is welcome to unmute, so we can just kind of try to address some of these questions. And as Dr. Benning said, if we kind of morph into our own Q&A as well, I think that's perfectly fine. I know I certainly feel some differences in terms of acute and chronic illnesses. And I never quite know whether to include sort of children with medical complexity within chronic illnesses, or whether that's yet like a third category to some extent, which isn't to say that cystic fibrosis isn't medically complex, but sort of kids with complex disabilities is also another piece. And I think a big piece is, in terms of at least opportunities for spiritual care, is that opportunity for ongoing relationships. So I was interested in your data that there wasn't a huge link between patients who'd had a visit before getting a visit in a subsequent admission, if I heard the data correctly, which is surprising to me, because when I think of chronic care chaplaincy, I think of the opportunity to build ongoing relationships.
Yeah, and that was an interesting part of the data which we included in the paper, but didn't include here for anyone who is wondering. But we did find that patients who use chaplain services in one of their admissions weren't necessarily more likely to then reutilize those chaplain services in a subsequent admission, which was a surprising finding for us. Does anyone have other thoughts on the concept Cate just raised about whether kind of these medically complex kids, often ones with developmental delay who are in the hospital frequently, does that seem like a third group in addition to the acute care and the chronic illnesses? Because I think there certainly are significant differences between caring for those populations.
It makes me think of the caregiver burden and how different that can be for a patient who is vent dependent versus not, right? What does it look like to be home caring for this patient? Some of these patients with epilepsy, for example, can have a pretty normal quality of life when they're not hospitalized. And I think of a lot of our complex patients where I am, or those folks who have developmental delays and other medical necessities where they need home nursing care and they're primarily at home. I think that some of the needs begin to differ based on what the experience of the family is, the system of the family is in caring for that child. So I could see some of that line of thinking. Kate, I think it's helpful for me to take a step back and think, do I just lump everyone together that's sort of chronic and complex that I see frequently in the hospital, or are there some real differences I need to pay attention to?
Yes, thank Doc. Very beautiful research. I really look forward to the final product. This is Chaplain Arthur Yanfo from the New Mexico VA Healthcare System. And yeah, brilliant work. But question number one, I'd like to chime in on that in terms of acute illness and chronic diseases or chronic illnesses. In my practice, especially when I was a staff chaplain, what I noticed in terms of chronic illnesses, you have the type of spiritual care that is requested, or at least that is desired, is more of a, how do I practice my faith? How do I refine my faith? How do I get to understand? How do I get deeper into my faith? And then in terms of acute illness, that's when folks actually, for example, I get a diagnosis today and it just freaks me out and I'm just scrambling. I'm looking for something to grasp onto. It's a kind of a desire for hope. And sometimes I'm listening to my medical providers and I hear everything they're saying and it's just going through my ears, one side of my head and throughout the other side. And that's when chaplain support makes a lot of sense, because at that point, a person, probably the only thing between that person and death or eternity is what that chaplain has to say. So it's more meaningful and is more, I guess, it's a kind of, I guess they're asking the chaplain for a shock or a boost of hope at that point in terms of acute illness. The chronic is just, I have questions, I need to go to confession and deal with some of my stuff. I have some time left, but acute is more abrupt. Give me something to hang on to, because my doctor is telling me things that are just going to blow my brains out of my head here, if that makes any sense.
Thank you so much. That strikes me too, and makes me think about something you said, Dr. Benning, in your presentation about the importance of giving adolescents a certain amount of autonomy in terms of, do they want spiritual care? And I think that one difference with chronic illness in pediatrics versus acute illness is chronic illness. Now in some cases, like certain types of epilepsy, children can have a fairly, certainly a good and a fairly typical quality of life. But some of these chronic illnesses like CF really do completely change a child's life. And in terms of like their world revolves around a hospital in some ways, and or doctors. And so I think that does shift the spiritual work that you need to do. And I think you hinted at that already, at saying, how do we give adolescents autonomy in this? I actually think that is spiritual work, and that is spiritual care. Sometimes I think the best spiritual care I can give an adolescent is giving them the opportunity to say no, and then listen to their no and honor it and walk away. Because I think that can be really important. And so I think with children and chronic care, that piece of how do we help them, spiritually integrate their constant experiences of hospitalization.
Yeah, Cate, adolescents are sort of a nice test population for the developmentally appropriate care. We try and provide spiritual care, medical care. And in some of these adolescents, if they have a new diagnosis of what will be a chronic illness, it can be very disruptive. But another issue, some of these adolescents have been dealing with their chronic illness for many years, and adolescence actually is a time of vulnerability where many will want to turn away from care in a way that can be medically harmful to them. And I think that's a real opportunity to look to other members of the care team, particularly chaplains, to say, how can you help them understand some of those implications of the decisions about wanting to, in some sense, deny a reality in their life and just feel normal. But then that can have a pretty negative impact for the cystic fibrosis patients, for the diabetics. It can literally take years, if not decades, off of their life expectancy, depending on their compliance of care. And that may be a real opportunity for chaplains, or if we're starting to see some of the children being admitted to the hospital when otherwise stable chronic care shouldn't result in that. The third point here of practices or questions, the third question about how do you do this in your institution, I think is of particular interest, because I think both Dr. Benning and I were struck by how low the utilization was, but we also didn't have a feel that our chaplains were just sitting around doing nothing. So if only 5% were utilized, but if we had a system where every patient that was admitted got a spiritual care consult, there's not capacity for that either. So how do you work towards the middle, increase utilization where appropriate, but not overwhelm a system that is already taxed?
That's the $1 million question. Right. And this is where I said, because at Transforming Chaplaincy, we're starting to plan a fairly large-scale multi-site research process on pediatric chaplain staffing, right? How does staffing, you guys had an actual difference, right? When you changed your staffing level in terms of utilization. So to me, that actually is evidence that exactly your chaplains aren't sitting around, because there was a clear, I think it was a significant jump. And so, this question of how many chaplains do we actually need to meet the real spiritual needs? Well, when people show up in the emergency room, it's not like it's incredibly obvious exactly what their spiritual needs are. And so then we ask questions. A lot of chaplain staffing and chaplain case finding, even if we have 40 chaplains for 100 beds, those chaplains are most likely trained, that's how I was trained, to case find somewhat based on acuity. We have an assumption in spiritual care, and it is being questioned, absolutely. So it's not an unquestioned assumption, but we tend to operate on this idea that spiritual needs track with medical acuity, which is exactly where chronic kids can fall through our gaps, right? And in terms of, it also has to do with institutional expectations, which again, aren't necessarily a bad thing, but my prior institution, if there was a significant medical emergency and or a death, the nurses and doctors I worked with expected me to show up. And so to say, actually, I'm going to be over here with this chronic kid who's not acute, but I have a long-term relationship with, that wasn't necessarily, how I could choose to spend my time. Now, I did want to show up for those acute events. It wasn't like, I thought that was an unreasonable expectation. And I think there is space for chaplains in acute events, and it is important. But this is this whole question of what do we value? Does spiritual acuity track with medical acuity? And how do we do case finding to actually pull this out? I hear a lot from folks that, spiritually screening or assessing every patient that comes into the hospital is unrealistic. I've tended to want to question that a little bit, which isn't to say that I think that, everyone should just work from 6 a.m. to 6 p.m. No, but I think if there were the proper investment in spiritual care and recognizing the importance of assessments, I think we could get there, but that would then, of course, be staffing levels also.
Amanda, I thought your point earlier about thinking about some of the more medically complex patients, and then when they end up coming in the hospital, the system that's already in place for them at home, for some people that's very disruptive, and for others it can be a period of almost respite. We've noticed some of our patients with chronic needs, if they come in the hospital for too long, they start losing the structure that needs to be in place for care in the outpatient setting. And so they get, the caregivers in particular, like, you got to get me out of the hospital. I'm going to lose what I need for the long term because of the short term here. And so being in tuned to those issues for the caregivers, in particular for these children that require long-term, fairly significant care, not hospital-based, but then end up in the hospital, whether it's over a short period of time with acute illness or for longer periods of time, if it's, they're having a significant change in their status. I thought that's an important thing that you brought to light there.
Thank you. I think a couple other things have popped up for me just listening to the conversation. One is that in both of the academic medical centers that I've been a part of, chaplain interns are the ones who are assigned to these populations, which create huge gaps in care and also create, I think, not to their fault, right? Chaplain interns are incredible learners and they are figuring things out every day. But there's a large gap, I think, in the care you receive between a chaplain intern and a staff chaplain who's a bit more experienced. especially with a new chaplain intern who's onboarding and just trying to figure out how to get in a patient room without freaking out, right? I'll speak for myself when I was a chaplain intern. So I think that this, for example, is helping me think about how to better advocate and have a voice for these populations that I think we do forget because we don't think of them as needing as much care. And they're not the places where crisis and emergency are necessarily happening, so they're not demanding our attention in the same way. The other thing I'm thinking a lot about is this piece that you raise up about staffing. And I think that I'm honestly just so grateful to hear providers say, like, we know part of the problem is there's not sufficient staffing. It makes my chaplain heart feel a little bit relieved that you know that we're working as hard as we can. And we have deep staffing issues in a lot of places, a lot of pediatric hospitals. And when we think about, I know we talked a little bit about adolescents, but when you think about children, especially younger children, you cannot make that assessment in 10 minutes in the room. In the adult population, it's a little easier to be with, for a chaplain to make a spiritual assessment quickly. I'm not saying it's always great to move very quickly, but when you're doing more play-based care and, you know, spirituality is not going to show up necessarily through belief and language and quite the way we would expect it with older children, adolescents, and young adults and adults. I think that the staffing levels have to be increased for us to really be able to meet those kinds of needs in this population. So I think it's layers of reasons why only, I think what you said, 5% of these patients are being seen in your setting. And it honestly, hearing your research makes me deeply hopeful because I think that we haven't had this language and this data to advocate from. And so I'm really grateful that as non-chaplains, you saw the potential to try to capture this. And you also did a beautiful job of capturing the fact that we also provide incredible care for and are needed by non-religious patients as well. So thank you for the work that you've done.
Yes, and I know in our own institution, talking to one of our pediatric chaplains on the staffing question, he basically told me for a long stretch of time, unless someone was actively dying, he did not have the capacity to see them. So he was just seeing the most acute of the most acute. And I think it's the kind of thing where as staffing levels increase, there's probably a very large population who could benefit. And when you're forced to kind of triage and only see the people who have the most emergent needs, that's who you see. But as you have more capacity, then you're able to see people who, even if their needs aren't emergent, they're certainly profound and can be really helped in a lot of cases.
Well, as clinicians, I think it was particularly important that Dr. Benning led out with some of the research behind medical benefits of spiritual care. You know, if that can help justify staffing, if we're trying to reduce costs of care, improved outcomes are something, you know, if we can add to that, there's desires, like people may want, they desire spiritual care, but if it actually improves their care, not only sense of well-being, but their compliance with, you know, standards of care of treatment, it reduces hospitalizations, things like that. That's dollars and cents, and that speaks loudly to some groups.
What's interesting is a lot of the evidence that we have about spiritual care actually making a difference in health outcomes, you know, if we follow that thread, actually comes from chronic care. And so, you know, we spend so much time, and again, I don't think it's a bad thing that we spend so much time in acute care, but we underserve, I think, because of staffing levels. You know, it's not our choice. We're not saying, oh, we're not going to serve this, but we tend to underserve, and or you know, families with children with chronic illnesses are underserved, despite the fact that that's actually where our strongest evidence base lies. And I think we're trying so hard in chaplaincy to move into evidence-based chaplaincy. That is the whole mission of transforming chaplaincy, of this research network. And so to me, it makes me ask the question, are we really committed to that? Because if so, I think we would be staffing and looking at chronic care in a somewhat different way.
And there certainly are staffing models too. One of the benefits of having an additional chaplaincy FTE is, you know, it allows some of our chaplains to be embedded with teams, with the palliative care team, to maybe make rounds with the hematology oncology team, some higher utilization, potentially higher need groups, so that there can be that joint care, that sort of integrated care, as opposed to the patient populations that we were looking at. We specifically excluded the hematology oncology because there's a lot more literature there, but it's also, it feels much more fragmented. We do our thing, you do your thing. You know, I feel like you're always trying to plan around when we're in the rooms and trying, but some of that integrated care can be very valuable.
This does make me think, and I'm always going, what's the next research study? It would be interesting to actually, if we've kind of created boxes here, we've got acute illnesses. I almost wonder if like cancer and or palliative need to be their own boxes, which is, we're getting complicated here. And then we've got, chronic illness and then complex care. It would be really interesting to sort of repeat this methodology. Again, this takes a different level of funding and time than most chaplain groups have, but, across a hospital, and actually get an idea of what the utilization rates are in these different areas and to see how much they differ, and then to do some work to understand why they differ so much. My guess is it will have to do with staffing. I think it also has to do with how we're trained and what our expectations are. But that would be a really interesting follow-on study that could potentially really make the case that chronic illnesses are underserved comparatively, and or might just make the case that everyone is underserved. Which I suspect will also be one of those pieces.
Yes, that would be really interesting. I agree. All right, well, I know we are down to our last couple of minutes here. So I just want to make sure we can get to our acknowledgement slide. So just wanted to acknowledge everybody who was involved with our research. Dr. Case is now an ENT resident down in Texas and will be coming back to the world of pediatrics as a pediatric ENT surgeon. And we have our pediatric chaplains at Mayo, Zach Lovick, Jeremy Gerard, and then Dr. Fisher and Dr. Thorvaldson, who are also involved in this research. And then we have the citation there of the paper that from this data, if anyone wants to take a look at that.
And I'll just put in a plug. That slide shows that this was a group of individuals with different interests and backgrounds, common interest, but some different backgrounds. And it was really Tyler that brought the statistical prowess in the study design, even though you could argue he and Hannah were the most junior members, but they brought some big ideas, and others of us helped refine those. And then the methodology, I think, really was quite helpful. So if you were going to try and either replicate or create new studies, bringing a good team together, it brings a lot of that background and perspective. It can feel a little cumbersome, but it really made this a much stronger research study, in my opinion.
Yeah, I absolutely agree. And we'll put up our contact information here. If anyone wants to get in touch with us to talk about this or future studies more, very happy to do that. And we'll just send you off today with a few pictures here. These are pictures from a study of kids with CF, and I believe they were asked to draw a picture of God with them when they were sick. So you can take a look at a couple adorable children's drawings before you get on with your day.
Thank you so much, Dr. Homme and Dr. Benning, for being here. You'll see, a few pieces here. If you aren't a part of the Transforming Chaplaincy Pediatric Spiritual Care Research Network, everyone is welcome. We're a fun group. Tomorrow, we have APC's Webinar Journal Club. So if you are signed up for the Association of Professional Chaplains for professional education, and if anyone does need a certificate for an hour of research education from us for attending this webinar, I'm happy to provide that for you. And then we also do have our TC research literacy courses, and one of them starts today. So if you're interested, do be in touch, and we're happy to put you with that. And as I had said at the beginning of this, the PSCRN is somewhat interested in taking a look at essentially replicating this research, which isn't, to take it word for word, but doing similar studies, because I think this is really vital for our field, is to get more data like this. So if your site or you are interested in exploring that possibility, as of right now, that's unfunded, but I can really work hard on pulling strings. So we can see what we could do, but we would love to talk to different sites. And in general this year, just really wanting to incubate some research projects that really matter for patients and families. Thank you all so much.
I think I'm safe to speak on behalf of our team, but we'd be more than happy to share all of our information, including IRB documentation. Dr. Benning is quite facile with statistical analysis. If nothing else, just how the way you went through the electronic medical record and gathered data. We'd be happy to share whatever if there's others that are interested.
Yes, absolutely.
Thank you guys so much. It's so nice to meet you. It's always a delight for all of us, I think, to meet clinicians who have an interest in these areas, are asking some of the same questions we are. It's wonderful. Thank you.
Well, thank you very much for having us.
Karen.